This HIV update provides an overview of hepatitis C coinfection, presented by Dr. Todd S. Wills. The activity planners do not have any financial relationships with commercial entities to disclose. The following speaker has financial relationships with the following commercial entities to disclose: Todd S. Wills, Grant Research Support, Gilead Sciences. This presenter will not discuss off-label use of investigational products during this presentation. This slide set has been peer-reviewed to ensure that there are no conflicts of interest represented in the presentation. Upon completion of this program, participants will be able to assess the changing landscape of hepatitis C, HCV, treatment in the post-interferon era, classify the appropriate HCV treatment regimens for specific viral genotypes and disease states, compare HCV treatment regimens with respect to drug interaction potential with antiretroviral medications, and identify patient, provider-specific, and external barriers to successful HCV treatment and propose strategies to overcome these challenges. The following statements relate to continuing medical education and continuing education. This session is approved for up to 1 hour of CE-CME. This enduring activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through the joint sponsorship of the Florida AHEC Network and the Florida Caribbean AIDS Education and Training Center. In order to receive CE or CME credit, you must complete an evaluation survey, which includes a request for CE-CME. The evaluation survey link will be provided at the end of the video. When asked in the evaluation survey, indicate that CE-CME is requested. You will then be directed to a survey that must be completed for our CE-CME provider. The CE-CME provider survey will include a post-test assessment. You must achieve at least a 70% in order to receive CE or CME. Participants will be able to print or save their certificates after successful completion of the post-assessment. Please note, if you received CE or CME credit for the live webinar that took place on May 7th, 2015, you are not eligible to receive CE-CME credit for this on-demand module.
It's my pleasure today to introduce Dr. Todd Wills. Dr. Wills is an associate professor at the University of South Florida, Morsani College of Medicine in the Department of Internal Medicine in the Division of Infectious Disease and International Medicine. He is currently the Program Director for Infectious Diseases Fellowship. Welcome, Dr. Wills, and I'll turn it over to you.
All right. Thank you, Maribel, and welcome everyone this afternoon. I think we have a interesting discussion today about advances in the care of hepatitis C. I wanted to start by looking at historically where our challenges have lied in the care of hepatitis C patients. This is a schematic done from a couple of years ago from some folks up at Massachusetts General Hospital. And if we look at these cups of water, we can see on the left only a fraction of those with hepatitis C are diagnosed. Of those who are diagnosed, an even smaller fraction, only about half at that point, were treated. And in the last cup, in the pre-direct-acting antiviral era, only a fraction of those treated are cured. The dynamic of these challenges are changing, however. With newer medications, people who are treated with hepatitis C now have a significant chance of cure. And because of that, there is not only greater optimism for them, there's greater reason to link those who are infected to treatment, and there's a greater motivation to find all those who are infected so we can establish those links toward a now successful treatment regimen. Why do we treat hepatitis C at all? Again, the reason that we treat hepatitis C is because of the hepatic complications that can arise with a long-term chronic infection. This is a look at survival probability for patients who have a diagnosis of cirrhosis related to their hepatitis C, and this is survival by months. Now, when we talk about hepatitis C as disease progresses and becomes worse, many patients progress to worsening stages of fibrosis, eventually to cirrhosis, where their liver is not able to do its normal job. Compensated cirrhosis is when, even with that impairment, they're still not having any identifiable liver-related complications, whereas decompensated cirrhosis involves complications. And those complications can include things like upper esophageal bleeds, development of abdominal ascites, sometimes confusional states. And those are the patients that can only be treated by that point with a transplant. So if we look here, the reason we want to treat people before they even get to cirrhosis is because once they do and develop any complications, their survival is markedly decreased. There, if you look at a 5-year mortality, the 60-month point, about 50% of those who have developed any single complication will have died related to their liver disease. If we look at the overall epidemiology, again, this is from an NHAIDS epidemiologic survey at the late 90s, early 2000s, we know that about 1.6% of the U.S. household population is positive for hepatitis C antibodies. That household survey excluded incarcerated and homeless individuals where seroprevalences are estimated to be higher. It's estimated that in the U.S., 4 million people have ever been infected with hepatitis C, and of those, more than 3 million are carrying a chronic infection. It's always important when we're taking care of our patients to identify the identifiable risk factors for hep C infection, and those include anyone with a history of injection drug use, blood transfusions before the year 1992, at which point we had better sero screening tools, and patients with higher numbers of sexual partners. Included in that risk group are men who have sex with men, and recently the CDC added the age cohort of individuals born in the baby boom population from 1945 to 1965 as having a high enough risk of hepatitis C that they merit screening for it as well. If we look at the prison population, 15 to 40% of the U.S. prison population is hepatitis C infected at any time, and that totals up to 300 to 400,000 individuals. This is an area where a lot of attention can be focused on access and linkage to treatment. When we talk about hepatitis C and HIV co-infection, the diseases do have an interplay with each other. First and foremost, because of a shared risk factor of acquisition. If we look at patients who have both hepatitis C and HIV, by and large, those who are co-infected have acquired their disease through intravenous drug use. However, there are small cohorts as well within the population that have gained their infection through sexual contact as well. For those who are co-infected, there's a higher rate of progression of liver disease than in those who are mono-infected with hepatitis C alone. There is some preliminary data that's controversial that also shows that hepatitis C can increase the rate of HIV disease progression. And for both diseases, we do know that there is a worse prognosis even when HIV is treated and immune strength is restored. This is important, again, because it identifies a group of co-infected patients that deserve a more urgent assessment for hepatitis C treatment even than those who are mono-infected. Another challenge in the treatment of the co-infected patients is that patients who might be at risk for liver-related toxicity from their antiretrovirals are at an even higher risk when they are co-infected with hepatitis C as well. We mentioned some of these on the previous slide. Other things that we can see with a co-infected patient, there's a 5 times more likely rate of hospital admission for liver-related complications. The DAD study, which is a large cohort study looking at overall outcomes and complications in HIV-infected patients, has found that liver disease in HIV-infected patients is the second leading cause of death after AIDS and before cardiovascular disease. As time has progressed and antiretrovirals have become more effective, we have even seen hepatic deaths and complications exceeding those of HIV-related complications. So although we've done a good job at treating and controlling HIV, there's a large proportion of co-infected patients who are succumbing to liver-related morbidity and mortality because of untreated disease. One of the first things we can do in designing our clinics to handle our co-infected population is to make sure that we have effectively identified all of our co-infected patients. And the mainstay of that is establishing antibody screening tests for hepatitis C. All patients who are HIV infected, should at least one time be screened for hepatitis C infection as well with a fourth-generation enzyme-linked immunoassay antibody test. For those patients who have ongoing risk activity, screening should be repeated as well. I'm going to take us through this algorithm quickly. For anyone who has a positive antibody test, the next step is to confirm their disease state with something called a quantitative HCV RNA test. This is a viral load test similar to those we use for HIV viral loads. If that test is also positive and detects and finds a detectable hepatitis C viral load, that patient has active hepatitis C infection. You can further classify their disease through genotype and evaluate them for appropriate treatment. An important part of the branch, once we check for quantitative hep C RNA, are those patients who have a negative test. That does not immediately confirm that they are free of hepatitis C infection because there can be some fluctuations in viral load detectability from time to time. So if a patient has first had a negative hep C RNA test, they should be retested 4 to 6 months later. Again, if that retest is positive, they are infected and should be evaluated for treatment. If negative, it means they're one of the 20% of patients who has had spontaneous resolution of their hepatitis C infection and require no further treatment or evaluation unless they have ongoing risk-based activity for new acquisition. If the initial hepatitis C antibody test is negative, the next thing you should look at for a patient is their transaminase test, especially their ALT. If they do have chronically elevated ALT, which is otherwise unexplained, those patients should also have a quantitative hep C RNA in case that the hepatitis C antibody test was falsely negative, and they are otherwise evaluated as you see. And finally, those who have a negative antibody test and normal LFTs really have no evidence of hepatitis C infection. They should only be rescreened if they have ongoing risk activity for new acquisition. So if we do find a patient who's hep C infected, what are our first responsibilities? Well, we do need to give them information so they can avoid transmission to other individuals. They should avoid sharing toothbrushes, dental and shaving equipment. They should cover bleeding wounds to protect contact of blood from other people. They should be encouraged to stop using illicit drugs, avoid reusing or sharing syringes, needles, or other drug paraphernalia. They should use clean injection sites and dispose of sharks appropriately. Patients who are hep C infected should not get tattooed. Again, that's another risk behavior for hep C acquisition is receiving a tattoo from an unregulated or unsanitary condition. Patients who are hep C infected shouldn't donate blood, body organs, or other tissues. And in order to decrease the rate at which their liver disease might progress, they should limit alcohol intake, preferably abstaining completely. For patients who are hep C infected, if they are found to have later stage liver disease with significant fibrosis, they should have regular screening for hepatocellular carcinoma as well. And this is the second complication of chronic hepatitis C. In addition to cirrhosis and the inability of the liver to function properly, patients with chronic hepatitis C are also at risk for the development of liver cancer. For any patient with hepatitis C who has a significant risk of development of hepatocellular cancer, they should be screened by ultrasound on a Q6-month basis. For our co-infected patients, this is recommended for anyone with hepatitis C who has cirrhosis, anyone with hepatitis B who has cirrhosis, anyone with hepatitis B who has a documented family history of hepatocellular carcinoma, And additionally, and sometimes a population group that we miss, any African or North American blacks with hepatitis B virus infection, regardless of the severity of disease. There are no differences in the screening recommendations in the presence or absence of HIV disease. So if your clinic is taking care of mono-infected patients, these criteria also hold true for hepatocellular carcinoma screening. Now, again, we said that we would be screening via ultrasound. Periodically, you will find a patient who has a liver nodule on ultrasound. This schematic gives us some idea of what to do based on the characteristics of that nodule. If you do have a less than 1 centimeter nodule, that can be screened by repeat ultrasound 3 months later. If it's stable, you can continue that screening paradigm. If it's growing or changing in character, it needs to be investigated in a different way. For liver nodules that are greater than 1 centimeter in size, they should be evaluated next with either a 4-phase CAT scan or a contrast-enhanced MRI. What we're looking for there is any evidence of hypervascularity or delayed phase venous washout. If either of these findings are seen on a nodule greater than 1 centimeter in size, they are considered diagnostic of hepatocellular carcinoma, and the patient should be referred for further evaluation to a hepatologist, oncologist, or other specialist. If those findings aren't seen, then it is recommended that whatever diagnostic modality was done, the opposite be done. So for example, if you first did follow-up evaluation with a CAT scan and you don't see any abnormalities consistent with hepatocellular carcinoma, you should also get an MRI to look at that to make sure there's definitely no abnormalities there. If neither of the studies show abnormalities, the lesion should be biopsied to really figure out what is clearly there, because otherwise there might be an occult hepatocellular carcinoma undiagnosed by imaging alone. For our patients with Hep C or any underlying liver disease that progress to cirrhosis, it is one of our responsibilities to make sure that we're either managing their cirrhosis to keep them compensated or sending them to a specialist who can manage decompensated cirrhosis. So again, as a reminder, things that are indicators of decompensated cirrhosis include things like the development of ascites, development of esophageal variceal hemorrhage, hepatic encephalopathy, which is a confusional state related to their hepatitis, jaundice that's not explained by anything except their liver disease, and again, the hepatocellular carcinoma that we mentioned recently. For patients who have progressed to that degree, the only thing that might be an effective therapy for them is a transplant. So one of the things that can be helpful if you do need to refer a patient for transplant is a tool called the Model for End-Stage Liver Disease Score, or the MELD score. There's a calculator available online, and I've left that link here. You could also do a Google search for this, just looking for MELD score, Mayo Clinic tool, and you'll find the same link. You, at that point, punch in some laboratory and clinical data about your patient. If you achieve a score greater than 10, that patient probably is in need of a referral for liver transplant. Based on where you practice, different centers will or will not transplant co-infected patients. Within the state of Florida, the University of Miami does do transplantation for HIV Hep C co-infected patients, and is a reasonable referral source for patients who may need transplant because of their hepatitis C. So those are some of the general responsibilities we have for our co-infected patients, even outside of active treatment. What I want to focus on now is the evaluation for patients receiving treatment for their hepatitis C, with the hope there being that we can avoid many of those complications we talked about by identifying patients early and treating them effectively before complications of liver disease set in. So first I want to look at historically where we were with hepatitis C. And this is not 20 years ago, this is really only a few years ago. We were in an era of high side effect therapy with low efficacy. If we look at the state of the art of hepatitis C treatment, from the year 2001 all the way up to 2011, all of our patients, whether they were mono-infected or co-infected, were recommended to receive a regimen for treatment of hepatitis C that was based on a combination of pegylated interferon and weight-based ribavirin. And usually this was for a 48-week treatment course. Interferon itself is a very high side effect medication. Patients feel significant myalgias, fevers, weakness, some with the inability to work while they're taking that therapy, which was required at that point for a year. Additionally, interferon can exacerbate underlying psychiatric disease. Patients who had a history of depression were at risk for attempted or completed suicide while taking interferon, and so required the active intervention and evaluation of mental health professionals during the course of their therapy. Additionally, interferon had significant effects on hematologic parameters like white blood cell counts and platelet counts. So all of those required high clinic-based resources in order to successfully treat a patient through therapy. The additional medication ribavirin, much lower in side effects than interferon, but still had significant issues with potentiating anemia for patients, as well as some drug interaction potential with some of our antiretrovirals. And despite all that high side effect hurdle to get over, if we look at the success of treatment with these regimens, interferon ribavirin-based regimens provided only a 46% chance of cure after 48 weeks of therapy. So any patient we identified and put onto treatment really had no better and slightly worse than a 50-50 chance of being cured. Because of that, clinics needed to put a lot of resources into place. These included things like substance abuse counselors, opioid dependence counselors, patient educators, peer-based counseling, group counseling sessions, clinic-based injections, all of that for less than a 50-50 chance of cure. So this itself was one of the barriers to treatment for patients. Clinics required too many resources to successfully convince a patient to be treated, to get them through treatment, and to manage their toxicity and side effects. But then in late 2010, moving into 2011, hepatitis C therapy changed dramatically, and we moved into what is now largely referred to as the era of hepatitis C direct-acting antivirals. And the reason we call it that is the interferon and ribavirin therapies of the past were non-specific antiviral therapies. They upregulated the body's own immune system to help fight viral infections, but they didn't specifically attack processes of the virus. The direct-acting antivirals are drugs developed specifically to inhibit mechanistic enzymes of the hepatitis C life cycle. And these have shown remarkable change in the types of results we can expect for our hepatitis C infected patients. So when we started in the era of direct-acting antivirals, the things that we were trying to do was to reduce the side effect burden of hepatitis C therapy by reducing therapy duration, by changing the components of therapy, perhaps getting rid of interferon completely, maybe getting rid of ribavirin, maybe getting rid of both, and in some cases even using laboratory tests or predictive biomarkers to find out which patient would be more or less likely to be successfully treated. And in that era, we utilized genetic sequencing of the viral genome to find specific targets for therapy. If you are used to hearing talks about HIV and drugs for that, this is not much different than that. We look for functional enzymes or structural proteins through which inhibition of their activity can lead to an antiviral effect. And by sequencing hepatitis C, we found many structural and enzymatic proteins. A lot of activity is focused on the areas both in the middle and to the far right as far as drug development. You might see areas there called NS2, NS3, NS4A. These are protease enzymes of the hepatitis C virus. The first direct-acting antivirals for hepatitis C focused on inhibiting the hepatitis C specific protease inhibitor. Newer agents are focused on the NS5B enzyme. That's a enzyme that, and NS in these cases, which I just recently learned, which helps me to understand a lot more about the naming of these, are non-structural proteins. Largely they mean they're enzymatic in some way. So non-structural protein 5B is an RNA-dependent polymerase, and this has been successfully inhibited and used for drug development as well. And the final drug category that has been utilized frequently lately is NS5A, another non-structural protein, but we don't know mechanistically what it does, but we do know that by blocking it, we can have a successful antiviral effect. Remember, in the pre-DAA era, before the direct-acting antivirals were here, we used interferon and ribavirin regardless of genotype. We might change durations, etc., but the drugs worked for all genotypes, just not well. In the direct-acting antiviral era, some drugs specifically work for some genotypes of hepatitis C and don't work for others. And since these are direct-acting drugs that work specifically on proteins in the virus, there is also the potential for the development of drug-related resistance that we didn't frequently concern ourselves with. So if we look class by class, the Hep C protease inhibitors inhibit the protease enzyme. They are genotype dependent, and most of the protease inhibitors that we have available right now have been effective for the treatment of genotype 1 hepatitis C. Hep C protease inhibitors also have a rapid selection for drug resistance. The nucleoside analogs, things that might inhibit the NS5B polymerase, are similar nucleosides to what we might use for HIV. They require phosphorylation to be effective, just like in HIV. They're chain terminators, and here they have similar activity against all genotypes and a high genetic barrier to resistance. And finally, some non-nucleoside inhibitors are genotype dependent as well, with a rapid selection for resistance. One thing, though, that it's important to note when we talk about resistance with hepatitis C is that this is a virus that is not integrated into our host cell genome. It is largely replicating within the cellular cytoplasm. That means the virus itself has a half-life, and genetic resistance to drugs that develop for hepatitis C also has a half-life. So if someone becomes resistant to a class of drugs, it is estimated that within about 6 to 12 months, that resistance mutation will have reverted back to wild type and is not archived in the genome in the same way we see with HIV infection. So again, if we look at the evolution of hepatitis C therapy, from 2001, we were in a pegylated interferon ribavirin area. In 2011, we moved to pegylated interferon ribavirin plus some hepatitis C protease inhibitors. And then in subsequent years, we've added many different drug classes, and we're still trying to figure out the best way to use these classes in combination. But regardless of what we're trying to figure out there, we do know that the newer drugs are remarkably effective with a cure rate far surpassing anything we had seen in the past. And we'll look at some of that data in the slides that come up. So again, this is another schematic looking at what we've seen in the development of Hep C therapy. Really, it's quite a foreshortened timeline if you look at the period between 2011 and 2015. Multiple new direct-acting antivirals have come out. Curability of hepatitis C without interferon was found to be possible. Interferon-free regimens were approved by the FDA for treatment of multiple genotypes of hepatitis C. So we went from an era where multiple clinic resources were needed to successfully treat a handful of patients to an era where very few clinical resources are needed to provide patients highly effective and curative therapy. So if we look recently at the DHHS guidelines for the use of antiretrovirals, they have added a special section on the management of co-infection of HIV and hepatitis C. First, when they talk about antiretroviral therapy, they don't make any distinction in the type of antiretrovirals you might give a patient, whether they have hepatitis C or don't have hepatitis C. But they do have specific warning about one concern, which is we have to be careful and consider potential drug-drug interactions with Hep C therapy, remembering that some might have overlapping toxicities and that some combinations are contraindicated. Now, this is important if you're initiating antiretroviral therapy with a plan to very soon treat a patient for hepatitis C. In that case, you may want to choose an antiretroviral regimen that won't conflict with whatever Hep C therapy that you're planning. If hepatitis C therapy is a plan, but in the distant future, you probably don't need to have that be a factor in the type of drugs you choose to treat your HIV. Remember that some older antiretrovirals have a higher risk of hepatotoxicity. These include things like D4T, DDI, zidovudine, nevirapine, and topranavir. Rarely do we see patients on any of these anymore. However, there may be patients who had successful virologic suppression on one of these older regimens, and for example, may still be taking zidovudine or nevirapine. And it's important to remember that risk of hepatotoxicity and change the regimen if at all possible if they do have underlying hepatitis C. Now, when we consider hepatitis C treatment, remember that we can concurrently treat both HIV and Hep C. Sometimes this might be complicated, and the complications could include things like pill burden, drug interactions, or overlapping toxicities. In my experience, the biggest complication has been drug interactions, and that's something that requires the most advanced planning when you're thinking of putting an HIV-infected individual on antiretrovirals on a regimen for the treatment of hepatitis C. Regardless of those complexities, though, it is important that all co-infected patients be evaluated for Hep C therapy and a decision made to treat them or not treat them, and if a decision is made to not treat them, to document why that decision was made. For all patients who you know have chronic Hep C, genotype testing for their hepatitis C should be done to plan therapy, and staging of the severity of their liver disease should be done. Disease stages help determine the need for Hep C therapy or the acuity of that need. Remember, and I hope we've gotten this point across, treatment with pegylated interferon and ribavirin is associated with a poor rate of Hep C clearance. We don't see a high sustained virologic response or cure. So therapy for our HIV-infected individuals, just as for our Hep C mono-infected individuals, should be based on regimens including direct-acting Hep C antiretroviral agents, or antiviral agents. Now, I had spoken previously about the biggest complexity in treating simultaneously HIV and Hep C is drug-drug interaction. I'm going to look a little bit at slides that might predict what interactions we'll run into. Things that we might have as predictable interactions are patients who are taking ritonavir or efavirenz, which have either inhibitory or induction effects on the cytochrome P453A4. And we still have to look more at direct-acting antivirals and ART regimens in healthy volunteers to see if there are unpredicted interactions that we haven't yet seen. However, studies have been done in co-infected patients with the direct-acting antivirals that are available on the market, and we do have a pretty fair assessment of the drug interaction potential of the medications and what things we have to watch out for. And what I have found is the most useful resource for looking at these interactions and determining how to adjust either the planned Hep C therapy or the patient's current HIV therapy is a website called hepdruginteractions.org, and I put the link up there in blue for you all to see. This website takes you step by step through the planning of a drug regimen for a patient. So the first thing you would do is choose the Hep C direct-acting antiviral that you might be proposing for a patient. You then can put in the antiretrovirals that they're taking and look for any predicted drug interactions. And this is a screen capture from the final report page you get. In this case, if we were looking at a patient who was taking co-formulated M-tricytamine and tenofovir along with boosted ritonavir, and we were planning to give them the direct-acting antivirals for Hep C, so sofosbuvir and ledipspavir, there is a predicted interaction between tenofovir and those drugs. And if you clicked on that, it would tell you what the interaction is and what plans you might need to make because of that. Other things that you might predict for interactions among some of the newer direct-acting antivirals, one of the Hep C protease inhibitors called cimeprevir cannot be given with efavirenz or etravirine or HIV protease inhibitors or cobicistat or the elvitegravir, cobicistat, tenofovir FTC pill. It can be given with many of the other integrase inhibitors and some of the non-nucleosides. In most cases, the integrase inhibitors for HIV tend to have less interaction potential with HCV medications than other classes. So sofosbuvir, which we'll look at in more detail soon, can be used with most other antiretrovirals, except it does have the potential of increasing tipranavir levels. Finally, ledipasvir, one of the NS5A inhibitors, which is available as a fixed-dose combination with sofosbuvir, also compatible with most antiretrovirals, but when co-administered with tenofovir or cobicistat or ritonavir, can increase tenofovir exposure. And that's what we had seen in that sample Hep C drug interaction slide previously. This is the interaction between tenofovir and the ledipasvir in the co-formulated regimen. Another approved direct-acting antiviral is what's called the Vicera pack. It's 3 different Hep C specific antivirals co-packaged together into single daily packets. There are many different drug interaction potentials there as well. It can be used safely with raltegravir and atazanavir and some of the other integrase inhibitors. And remember, since this is a dynamic field, rather than trying to remember all the drug interactions when new direct-acting antivirals become available, I think a useful tool like the drug interaction website is something you can rely on to look for predicted drug interactions and plan your regimens appropriately. One thing to remember about this drug planning, when we're looking at what the Hep C medications might do to our HIV regimen, we usually are only planning to give these Hep C medicines now for 12 up to possibly 24 weeks. So it's not unreasonable to plan a temporary change in antiretrovirals while completing Hep C therapy and then go back to a baseline regimen at a later date. So again, just as a warning, I wanted to talk briefly about those drug interactions. What I want to look at now as we get closer to the end is some of the data about the currently available direct-acting antivirals so we can look at where they might fit into our treatment armamentarium. The first slide here is one that's looking at monoinfected Hep C patients, and this is the NS5B inhibitor sofosbuvir used in combination with pegylated interferon and ribavirin for a 12-week course. What you see on the y-axis of all these graphs is something called an SVR12. That's a test for a detectable viral load 12 weeks after the completion of therapy, and it's considered clinically synonymous with a hepatitis C cure. So when this regimen was used, sofosbuvir, interferon, ribavirin for 12 weeks, 89% of individuals with genotype 1 disease, 96% of individuals with genotype 4 disease, 100% of individuals with genotype 5 or 6 disease had a sustained virologic response. Compare that to our pre-DAA era of a 46% cure rate. We're now at typically 90% or above. Most of the patients we would propose treatment for would be successfully treated with these regimens. And this success was true whether a patient had cirrhosis or no cirrhosis. Patients did a little better, 92% cure rate if they didn't have cirrhosis, but even 80% of those with late-stage cirrhosis on biopsy or other assays were cured of their hepatitis C with this regimen. And again, remember, this is one of the classes of drugs, the NS5B inhibitors, that are effective across multiple genotypes. This study looked at the same regimen, sofosbuvir ribavirin, again without interferon in this case, and found a 98% cure rate in patients without cirrhosis, a 91% cure rate in patients with cirrhosis, and that was for a 12-week regimen. Similar things were found with a 16-week regimen. When they compared this to pegylated interferon and ribavirin, again, these success rates far exceeded those seen typically. The success rates for interferon ribavirin, though, in genotype 2 have historically been higher than genotype 1, so this effect was not as dramatic as that 50% up to 90% difference we saw with genotype 1 disease. And finally, we see the same thing with genotype 3 disease, an overall cure rate of 93% for patients who were given 12 weeks, or I'm sorry, an 85% cure rate for patients giving a 24-week course of sofosbuvir and ribavirin in genotype 3 disease. And this carried through again for patients with cirrhosis or without cirrhosis, and patients who were treatment naive or treatment experienced. So again, sofosbuvir was one of the earlier direct-acting antivirals to be approved, showing success rates across multiple regimens. Now, a lot of times we're dealing with patients who have previously already failed treatment. In some cases, the patients, when they were using interferon ribavirin in the past, had no virologic response at all, and that was something we called a null responder. In these studies, using a combination of the sofosbuvir plus a protease inhibitor, cimeprevir, we saw remarkably high cure rates in patients who were null responders with various different fibrosis grades. In a study called Aviator, which looked at the combination drug by that you find in the Vicera pack, naive patients were cured, but null responders were cured in 93% of cases as well. So these are remarkably effective across patient populations where we previously had no successful treatment. It's important for us, though, when treating co-infected patients to see, do these agents or drugs work in patients who are carrying an HIV infection? And this study, called the Eradicate study, was looking at antiretroviral treated and untreated patients who were co-infected. The study is still ongoing, but so far in those patients who are HIV infected but untreated with HIV, 12 weeks of sofosbuvir ladipsivir led to 100% SVR12. 100% of those patients cured. We're still waiting in the arm of those who are on antiretroviral treatment. That one's taking a little longer because of the changes in regimens required to avoid drug interactions. Those last few slides we looked at were largely looking at sofosbuvir. The other big drug available on the market right now are the multiple components of the Vicera pack, which are dasapuvir, omisvavir, and Abbott 450. These are co-formulated and given along with ribavirin for usually typically about 12 weeks. The Sapphire study looked at many, many patients for efficacy of this particular drug. This was a placebo-controlled study looking at cure rates across multiple different things. Again, this multi-drug pack contains some Hep C protease inhibitors and other drugs that are genotype specific, so the studies were done specifically for genotype 1 disease. You can see that there was a wide range of fibrosis grades, most patients having early disease, but ranging up to higher degrees of fibrosis over time. Most of the patients were white, Most of the patients were male, so it can have some impact on the generalizability of the study. But when we look at efficacy, it tends to be quite remarkable. So in all patients who were given this combination of drugs, there was a 96% SVR12 or cure rate. When we break that down into just genotype 1A patients, a 96% cure rate. When we add our genotype 1B patients, a 96.7% cure rate. And what I want to point out on some of these previous slides, most of our drug studies look for what's a concept of non-inferiority, that whatever we're giving is no worse than the thing we're comparing it to. It's very difficult for a drug to show that it is superior to another drug. And in this case, to show superiority over traditional therapy, 70% of individuals would have needed to be cured. In this case, 96% were. So far superior to anything we had previously had for treatment. This slide, I think, is interesting because it looks at the differences in cure rate, and this is again in the Aviator study, the multiple drugs in the Vicera pack. It looks at cure rates in groups of patients that we had previously identified as harder to treat or less likely to respond to therapy. Traditionally, men have responded far worse in hepatitis C treatment than women, but in this study, men treatment naive had a 92% cure rate compared to 94% cure in females. When they were previous null responders, the same was seen. Regardless of genotype 1A or 1B, success rate above 90%. Regardless of how high the viral load, whether we're talking about a viral load greater than 7 log or less than 7 log, somewhere around or above 90%. Regardless of fibrosis grade, whether early or late, cure rates above 90%. And then the final category is something that you see non-CC or CC. These are genetic markers of something called the IL-28B genotype, and traditionally patients who have a CC genotype responded better to therapy than those who didn't, but largely it was a measure of interferon responsiveness. And again, these new direct-acting antivirals are so potent and effective that it wipes out any difference in effectiveness there as well. So I think this is a pretty good snapshot to say most comers to your clinic, gender non-specific, viral load non-specific, fibrosis grade non-specific, can find an effective therapeutic regimen. This is the same study again looking in genotype 1 Hep C patients. So far they've looked at a 12-week treatment course versus a 24-week treatment course of the same drugs. With 12 weeks of treatment of the Vicera pack medications, 93% cure rate. And again, there's a lot of detail we could go into in these drug studies. I think as new drugs become available on the market, it's important for all of us as providers for our patients to look at the details of the drugs, to look at the interaction potential, to look at how its efficacy might be compared to something that we're already used to using. But overall, the message I really think we need to be giving our patients, our clinic staff, and other providers is that hepatitis C is a completely different animal than it was 10 years ago, 5 years ago. It's eminently treatable. Any patient who has Hep C should want to find out about it so they can be diagnosed and get on effective treatment as soon as possible. The treatments are, in fact, so effective and the side effect profile so low that one of the questions we really need to ask ourselves is this something that even requires specialty care? Can the care of hepatitis C patients be moved out to primary care providers? One of the models that has done this effectively is something called the Project ECHO model that was piloted in New Mexico, where they provided telemedicine support to outlying clinics in rural areas and found that that can be effective. And that was effective even in a high side effect, high complexity therapeutic regimen. So when we're talking about single pill regimens taken for short duration with high efficacy, it's definitely something we might be able to consider moving toward primary care. So one of the things we have to look at, though, are the overall priorities we have for care. As more and more drugs become available, the complexity of our decision-making might be harder. But as the new drugs become more effective, we also have to ask questions as to whether we really need any more classes of drugs. Do what we have now available for choices cover all the needs we have and limit only to a few patients those who need specialty referral for less accessible or harder to use drugs? We're looking for shorter duration, so patients are exposed to less side effects, less cost, and the fewest drugs possible. And then that final circle up there is cost, and this is the one that I think we may even have discussion about in our Q&A session. We haven't talked about the cost of the medications in the slides here, but if we were to identify what is now the greatest barrier to the treatment of patients with hepatitis C, it's not convincing them to take medicines, it's not managing their side effects, it's not getting a patient advocate to convince them that their experience will be okay. The main barrier to treating a patient is cost and accessibility and insurance approval. So our strategies now have to be, how can we advocate for our patients? How can we use our clinic resources to get available drugs for patients, either through insurance funding, through patient assistance programs, or through other means? As providers, we are unlikely to be able to have a direct impact on the cost of medications, but we can, at least through our knowledge, lobby for our patients and advocate for them, letting third-party payers know that HIV patients progress to end-stage liver disease twice as fast as mono-infected individuals. HIV patients have resources in their clinics to help them through a successful therapy course, so they have a greater chance of adherence and completion of therapy. And we need to arm ourselves with that knowledge so that when we might face a denial because a patient isn't an ideal candidate for therapy, we can advocate for them and try to get that approval. Because what is still true for most patients, when you're seeing them in clinic now and they are telling you that they're ready to take therapy, that's the best time to get them on treatment. They may be sicker 5 years later, and their insurance company may at that time be willing to pay for meds, but they might be lost to follow-up then. So we want to identify, get them treated, and get them the access that they need as soon as we can. So I see we're getting close to the time where we'd like to open up for questions and answers. I just want to let everyone know in summary, in the new direct-acting antiviral area, cure rates for hepatitis C have significantly increased. Newer agents for hep C treatment result in cure rates approaching 90%, and the treatment duration has been cut in half, and in many cases to a quarter of what it was in the past. It is vital for us to identify patients chronically infected with hep C so that we can decrease the long-term complications of untreated infection. And with that, I close the presentation portion, and I'd like to open it up for any questions.
It looks like we have one question coming in, Dr. Wills.
Okay.
The question says, what if you have a patient who was previously treated with interferon and ribavirin? How do you know if they were cured or not, and how do you treat them?
Sure. So if they tell you that they were previously treated with interferon and ribavirin, and they're not sure whether they were cured, the easiest way for you to evaluate for that is to check a hepatitis C viral load. If it's undetectable, then it's very likely that they were cured. And again, you would then go back to that algorithm about testing and retest them only if they were still engaging in risk factors for new infection. If they had a detectable viral load at that point, then they fall into the category of treatment failure. And there used to be a lot of complexity in deciding whether they failed treatment after having a viral response, etc., or whether they never responded at all. In most cases, regardless of what happened with their interferon and ribavirin in the past, if they failed that treatment, you now decide their treatment based on their current fibrosis grade and their presence or absence of cirrhosis. Whether they failed interferon or ribavirin or not plays less of a role in what you choose currently.
Thank you. Looks like we have more questions coming in. The next
Sure.
question is, what is the average cost you have seen?
The average cost for these medications, the new direct-acting antivirals, is about anywhere from $75,000 up to $90,000 for a 3-month treatment course. So, unfortunately, these medicines have been priced in a way that they are unaffordable if a patient were in any way to try to acquire them without insurance funding or funding through a patient assistance program. What is important to note, though, is although those costs are high, treating and curing hepatitis C still defrays the costs of complications of liver disease down the road. I don't think that is a reason to advocate for high-cost medications, but it is a reason to advocate for your patient to get them, if you can, through any funding source.
So we have another question, Dr. Wills. And
Sure.
The next question is, for a newly diagnosed co-infected HIV and hepatitis C patient, would you initiate hepatitis C therapy first, followed by HIV therapy if the T cells are stable?
If the T cells are stable, and in this case, what we've typically had as our threshold, if you have someone who at least their CD4 count is above 100, I would initiate their hep C therapy first because the duration of treatment is so short. You're going to be able to be finished with their hep C therapy without having to have that confound your HIV antiretrovirals. It's an even easier decision if you're talking about someone whose CD4 count is 500 or 350 to 500 or above because they're not really in any immediate immune risk. It's a little trickier, again, for those that are between 100 and 200 because they are at some degree at risk for complications related to their immune deficit, and so you might take it on a case-by-case basis. But it's unlikely in the short time of a hep C treatment course that you're going to have a remarkable immune decline for that HIV-infected patient.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, FCAETC.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.